So I want to thank everybody for coming. We sincerely appreciate you having taken time with our students, with our trip, and for participating in the conversation about healthcare innovations. And I know that you have so much happening in the Netherlands that's exciting to us in the US, and so we hope to learn more from you. And to make ourselves available, should we be able to reciprocate and host you for a visit someday, we would be honored if that can happen.
Sweet home Alabama.
Sweet home Alabama, that's right. So, cheers.
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 Thank you for inviting us.
There's one over here.
Oh.
Ah, yes.
Yeah.
So I wanted to ask if we could go around just to do a little bit of introduction. Some of us know each other, but not everybody. So, Deja, would you be willing to start us off?
Sure. I'm Deja. I'm a second year graduate student at UAB, studying health administration and business administration, and getting ready to go to a fellowship after this year to work full time and get some experience.
In a physician group, right?
In a physician group, yes.
A management fellowship.
Yes.
And a physician group?
Oh yeah, physician group.
Mhm.
A group, right?
Physician.
Yes.
Remember, we have very large,
Yeah.
non-hospital based physician organizations, which I know are less common here.
Yeah.
And they're big enough now that they can take on management trainees, management fellows.
What kind of specialties do they?
Yeah.
We have a lot of different, so they're more like outpatient type clinics. So we have a neurology clinic, arm and hand. There's a lot, there's a lot of
Okay.
orthopedics, like anything that you can
Anything.
do outpatient, yes.
Jen?
So my name's Jenna Tenorello. I'm also a second year master's student in healthcare administration as well as business at UAB. Before I started in my master's program, I worked as a nurse, mostly in the emergency department, for almost 10 years. So I'm taking that with me as I move into the management side of things. I'll be doing my fellowship with Ochsner Healthcare based out of New Orleans, Louisiana. It's a big multi-system or multi-hospital system, healthcare system in the Southeast.
Hello everyone, my name is Jamie Kiwai and I'm working as a policy officer at the Ministry of Health, Welfare and Sport. And the direction PZO is patient and care structuring, if I translate it correctly. And my focus is outcome-based program, in which I really specify myself on shared decision making in the healthcare system regarding hospitals. And I have a background, I did a PhD regarding interprofessional collaboration in palliative dementia care.
Thank you. My name is Phil Sindoma. I am on faculty with Dr. Stephen Howard at the University of Alabama, Birmingham Health Service Administration, Department of Health Service Administration. Anyways, I teach in the undergrad, master's, and PhD level there, as well as our nursing school. I teach healthcare finance. My professional experience is in hospital administration. I was a hospital operator for a number of years, and also in the health insurance field prior to that. So got to see both sides, the payer side as well as the delivery care settings, with a strong focus on hospital operations.
Okay, I'm the ring-in for this evening. So my name is Kerry. I'm the Dutch connection for the group for here. So I've lived in the Netherlands for 11 years. I live in Amsterdam. And I'm the tour coordinator for this group. I'm also an educator. So I have been a teacher, trainer, adult educator for most of my life. So doing this helps to fuel my passion for education and learning, and also learning about the other side of the Dutch healthcare system, which I am a part of as a citizen of this country as well. So that's me.
Okay,
And I'm originally from Australia.
she's done an extraordinary job. We haven't missed a bus or a train or anything. We haven't lost any students. That would be important. Everybody, we got into all of our attractions and mixed them in with all of our wonderful professional visits. So thank you.
So she deserves a drink tonight. For sure.
Maybe 2 or 3, depending on the students and the faculty. Don't even talk about them.
No.
They're quite.
And I'm sorry for being a bit underdressed, but it was a late inclusion. So
And we came from pancake boat to
Chowder.
to here, so it was. Sorry.
My name is Pieter van der Kerkhoven. I know Steve through because he was visiting Erasmus University 3 years ago, and since then we have been in touch on various fun occasions, together with Phil, of course. And I know some of you as well. Like I know Thomas as well, because he used to be. We used to be in the same room doing our PhDs together with some fun times. After doing I did my PhD there in digital healthcare and how to develop it in a collaborative way by using techniques from design, so collaborative design. And now I'm working as an assistant professor in Delft University of Technology at the Delft Center for Entrepreneurship. So I'm working on healthcare innovation from the patient care professional point of view. So how to help them create some interesting ventures. So that's me.
Last year, Peter took me on a tour, and I love how you did a very Dutch thing, but it was sneaky, but in a really cool, exciting way. I wish we had it on film, right? I get there and said, we're going to go tour the incubator, which he knows I love this. Yeah. And it's, well, I thought, we'll drive over there. Oh, no. We have a bike for you. I am one of those 5 Americans who does ride a bike, not very well, but I do. And so we had a good time. And we had a headwind, but we
it was actually the biking was quite heavy that day.
It's like today.
And we have a very long time.
afternoon in Gouda, you have to take the bike also?
I
Yeah.
It was best that we were.
Extraordinary work happening in the incubator. I know that's in close conjunction with your department, so that speaks well to you all.
Yeah.
Yeah.
My name is Bianca Buik. I'm the Managing Director of the Rotterdam Stroke Service. I have a PhD in stroke and amputation rehabilitation. Work as a Managing Director, but also as a lecturer and researcher. I do a lot of things.
Yeah.
We learned about a lot of it.
Yeah.
It's wonderful.
No, my name is Anne de Gaat and I'm a nurse in the district in the aftercare for after stroke.
My name is Ruben van Leiden. I'm a medical doctor here at the Erasmus Medical Center. I'm a senior PhD candidate. My thesis mostly involves developing an application for use by paramedics in the pre-hospital setting to reroute patients to improve functional outcomes in the long term. I'm also a resident at the neurology department and I'll continue my training to be a neurologist in a couple of months.
So where are you doing your PhD?
At the Erasmus Medical Center, Department of Neurology.
Okay, so you are working in neurology.
Yeah.
Okay.
Yeah.
Ruben shared a lot of his research yesterday with the student group, and
Nice.
super interesting. There's so much potential gain for health, for patients, improvement to the system that can happen from that. So very exciting work.
Did you record it?
We tried. We'll see if it worked out.
Well, if you could please share your, because I can be there.
Only with his consent. This is exclusive.
Yeah.
I'm sorry, this is IT protected, so. But if there's any non-disclosure, I can sign.
Well, yes, of course.
I can also send you the sheets.
Okay, thank you.
Yeah, sure. Patient information.
Thomas?
I'm Thomas Reindersma. I'm a final year PhD candidate at the Erasmus School of Health Policy and Management, and that's also where I met Steven. Our collaboration already culminated in one paper, so hopefully many more to come. My research focuses on alternative payment models, alternative purchasing arrangements in medical care, so in oncology, but also looking at more cross-domain types of care, social care, health care, looking how purchases can stimulate innovation across the interfaces of those types of care, and how they can stimulate the adaptation of novel care arrangements. So that's what my research is about.
I was so thankful though in Case House who could not join us tonight, but
Unfortunately.
no. But I came. He hosted me here for a Fulbright and sabbatical, and when you're coming in a new place, you never know exactly how that's going to work. Will you put me in some office or something, or would I just have to sit out in the lobby? Although you have a really good coffee machine, remember? I hit that quite frequently. So I think they need to buy a new one because of me, but I wore it out. But I was in with the PhD students, with both of these guys, and it was so much fun because I got to know you both, learn more about what you're working on, share perspectives and
Yeah.
life experiences. So it was very valuable. I'm glad that worked out the way it did.
It did inspire me.
Yeah.
Anything I can do to help, it's always my pleasure. So.
Was it COVID lockdown?
We were in that lull,
Yeah.
right in between.
Just,
So
I
yeah.
just had a new management assistant and we invited you at Laurens
Right.
and I asked her, please go get some coffee and tea for us. And she looked at me, where can I get that? And I thought, okay, we were working for a half year with each other, but she has never been on the workplace before. We
Yeah.
did everything online, so she asked me, where can I get coffee and tea?
Yeah, it's just crazy time.
it was funny because I'd been planning with Case all along and the U.S. State Department for the Fulbright funding, and we knew like this might fall apart at the last minute before you get on a plane to fly to the Netherlands. And it all worked. Things opened up right before. We were here 2 months, and within a month, things closed back again.
Yeah.
So I was very,
Second
very lucky.
lockdown, yeah.
Yeah, you left before that, right?
I did,
Yeah.
just barely. Yeah, and no mask mandates, so it was very convenient.
The Dutch lockdown was very soft.
Right, compared to some places, right.
Very healthy cookies from the Koekelaar.
Oh.
You know the Koekelaar?
Yeah, I know, but I'm not sure if they're
No,
that
they're not
healthy.
healthy. Not at all. They look very healthy with grains
That
and
tastes great.
berries, and they look very healthy, but they're really buttery.
Well, and that's interesting. And we talked about the ministry. I think it's unique. You could tell me about other countries, maybe you've seen do this, where sport and wellness are explicitly in the name, wrapped in with the Ministry of Health, because we don't conceptualize it quite this way in the U.S. So, if you want to share anything about the ministry, the vision, and how activity maybe plays into
Yeah, I think
the
there's
vision.
a lot of focus on lifestyle, and it is really in primary healthcare, the GPs, physiotherapists, it's really displayed to, well, society in its whole, why physical activity is so important, why healthy food system is important, and I think that really aids also the healthcare system in its whole. So yeah. It's not something that I, from my program, focus on, but I notice in other departments that there's a lot of focus on that. Yeah, a lot of campaigns and a lot of activities that are part of the basic package of insurance that you can use to work on prevention as well. So you have different budgets that we as society can use for those kind of things. Yeah.
Would that include like a gym membership kind of thing, or like a?
Not gym membership, but I think a lot of things concerning prevention that's more, well, you have a basic package of insurance, but also additional package.
Mhm.
And that includes physiotherapists, like you can go on more times to physiotherapists and those kinds of things, but not gym. No, unfortunately not.
Well, you laugh, we do this in some of our insurances.
Mm-hmm.
Because physical activity is such a challenge culturally, but also there are built environment challenges, right?
Yeah.
I just moved to Alabama less than 2 years ago, and there are very few safe biking structures, right? Opportunities. The paths that you have that are normal here are very uncommon there. So where I biked before, where I lived, because they transitioned the old railroad beds into walking and biking paths, they weren't conducive to biking to work. They were conducive to biking for recreationally, to do something. And we just don't have much of that in Alabama, and that's got to be one component of a very complex problem with cardiovascular health and chronic conditions. So that's why I wanted to hear more about what's happening in the Netherlands, or what are ideas that we could learn from, because we do have to sometimes, especially in our Medicare Advantage program, the private insurance version of our elder insurance. They include a gym membership with the benefit package very often, not always, but often, to try to encourage people to be active in an environment where it's not conducive.
There are some employers
Well, yeah.
that offer that too.
That's what I was gonna say. It's
Yeah.
our employer groups will do that too, because they know that a healthier employee is more productive. Plus, they pay a big portion of the health insurance, and if they have a workforce that's very unhealthy, their costs are going to go up as well. So they will sponsor or help gym memberships, smoking cessation programs, things like that.
Yeah, we actually at our ministry we have inside of the building we have a gym,
Yeah.
and we get discount to go to the gym. And also in our working environment, we have a table that that you can how do you say that? Stand, sit down, that you
Raise.
can raise. Yeah, and yeah, these kind of little things really help you as an employee
Absolutely,
to
yeah.
stay active as well.
We have one insurer that has an offering that includes an Apple Watch.
Oh, yeah.
And if you use the Apple Watch and work out regularly, you can get a discount on your premium. So that's one way that maybe insurers can stimulate activity, workout. But
Now, is that in the traditional basic insurance package? It's not a supplemental?
no, it's supplemental, but you don't really have to pay for it. So it's an extra offering, and you can get a discount on your premium. So, but only if you work out regularly.
Right?
Yeah, but I think.
What qualifies as regularly?
Yeah.
I like one
So
here.
Once a year still.
I don't have one, so.
So I've encountered those before
Yeah.
in the workplace, right?
Yeah,
Probably you have
absolutely.
Phil as well. And it's an old foggy memory. I want to say it was something like an average of twice a week to
Yeah.
meet the threshold
Yeah.
so that it,
But think about every day they are walking and biking to work. That is working out for us.
Yeah.
So every day it's exercise minutes being logged on a wearable.
Yeah.
Wearable.
some of us have been kind of joking, but not really, looking at our pedometer since we've been here. Like, woo, our physical activity has doubled or tripled.
Yeah.
Because
And that's the same when I said to you, we're going to Hotel New York, and I said, oh, that's walkable. And then you said, I think we need the water taxi. And I thought, okay, yeah. In American, in Dutch, we think, oh, 2 kilometers is great, it's just a nice walk. But in America, 2 kilometers, you do
it's
it
a long ways.
with a taxi. Yeah, but it isn't.
We did walk from the train station, from the subway station, right?
Yeah.
So that was
Did you walk?
No,
Half
that was 10
No, no, no,
ten
we
minutes
took the
or
metro. We took the
You walked from the-
shortcut.
Yeah.
But still walked. Yeah. Yeah.
Well, there was no other option really, was there?
Yeah, but I was gonna say that it's also a cultural thing because I don't know how it is with children in the US, but like I noticed with my son that in our environment in Belgium, it's you see people cycling on TV. You see it when you go to school. People drop their children off at the daycare at school, so the children see it from a young age already, and you teach it as well to your children. From my son is now 2 years old, so it's also like something that is normalized.
Mm-hmm.
My wife is from Italy, and there it's not like you can still do it, but it's not productive because you can't cycle to daycare there with your child. So why would you teach it? So it's something cultural. It's part of a bigger cultural thing as well. But that's just the cycling. I mean, the rest, of course, is other. I mean, there are so many parts of lifestyle, but cycling specifically, I think it's.
Is everyone ready to order?
Yeah.
No, I will say that I have a sister-in-law that lives in Brooklyn, New York City, Brooklyn, and when we go to visit her, we behave like you all behave here. We walk. We don't drive. Once we go, we park our car, and then we don't see our car for days. And we walk everywhere. Subway, we walk. We don't have a bike there, but we walk everywhere. So bigger cities in the U.S., Chicago, New York City, Boston, very walkable, very conducive to bicycles. Just where we are in Alabama, or even I grew up in Las Vegas. Yes, it's a big city, but it's not pedestrian friendly. It's not public transit friendly. You just get in the car and you drive those 2 kilometers because why? Well, you can't. There's no sidewalks or path to walk those 2 miles or kilometers.
Yeah, from casino to casino.
Yeah. Yeah. The casinos are just pretty much the same.
And sometimes weather is a barrier. So in Alabama, it can be quite hot and humid in the summer. So you would be dripping with sweat if you walked very far. many days, not all days, but many days. But as Phil was saying, the built environment, just 2 months ago, I think it was, my wife said, "Oh, I'll drop you off at this store and you meet me over at the grocery store, I'll go over there," okay? And it was half a kilometer, taking my life in my hands because there's no sidewalk. So I'm walking on the grass, right, on a little bit of a hillside, and then there's no proper sidewalk, so I'm waiting for a break and then running because there are no lights in that particular area. And then some of this is not very repairable. So since World War II, we have the growth in the US of the suburbs. And so the geography of cities is so spread out geographically that, I mean, I live 25 kilometers from work. I can't walk that. There's no public transportation. That's kind of far to bike, even if there was a path, it's kind of far. So you have to drive, and that's very, very. I'm a little bit farther than most of my colleagues, but hardly anyone is less than. I mean, a few people live in the central city, right? But most of us are at least 10 kilometers away. That's hard to surmount that problem.
And even then, I think there's also a difference between facilitating it and incentivizing it. Because recently I heard something really revolutionary. My sister, she works as a copywriter at a very green and progressive company. And they are actually allowed to do physical activity for 2 hours during working hours. So then there's really no more limitation not to do it because you can take a break from work, you can
being paid.
physical activity. Yeah, while being paid. And the company figures we have healthier employees, they're more productive if they're physically active, so it's kind of like a win-win. But it's hard to incentivize employers, I think, to go and do that because a lot of them will probably think that will reduce productivity. But in the long term, I think it might just be very beneficial for all parties involved.
My school did do it also, like this way.
Say that again.
My son is working also in university, and he has movements local stairs, and then he can walk after he's working on the and he walks.
Oh, so he's got
Like a miniature treadmill where you can walk.
Where's she hiring for a company?
It's a treadmill or like a bicycle?
Treadmill walking path.
So you can walk and like at your standing desk. Standing desks just became a thing like recently, and so people can stand up instead of sitting down all day, which is what I'm gonna have to do when I'm at
But it's not a tip. It's just changing your posture, so it's a little better ergonomically.
But then you can get a walk.
Then you can do both. Although I have to say I've tried it and it's kind of hard to focus on doing both things at the same time. At some point you're focusing on your pace and you start to lose your attention to focus on things. So doing it at the same time, I'm not sure how efficient it
A lot of
is.
coordination.
Yeah. Maybe I'm just a guy, I can't multitask. Maybe that's the problem.
We're talking about human behaviors and health behaviors that contribute to some of these problems. I wanted to get you to weigh in on some human-centered design issues, your experiences, your thought, maybe your students or colleagues' works about what are some innovative ways to think from that patient perspective where we can have innovations that can improve some of these health behaviors. So are these things that you all have been talking about at Health?
Yeah, we talk about them, but doing them is a different story. Human-centered design is a specific area from the industrial design faculty, so that's really a design area. They do work a lot on healthcare, but they typically develop things that are made for people, but not take it to clinical practice per se. So the full story to develop something from patient needs that fits their behavior. And there's a whole research area also that's called like persuasive design or non-persuasive or ethical, anything that would fit the life of the person. If that's done well, you could have a very successful product in theory. That's not really done right now. But so right now, that's one area I'm very interested in, is how can you help these human-centered design solutions that are fit for the patient or for people to use. How can you actually bring it to clinical practice in a scalable way? Scaling solutions in healthcare is one of the biggest challenges in my opinion. Yeah, it's just I don't know if that's...
Yeah.
So it's really an implementation challenge, if I make
Yeah, but implementation is also depending how you define that, because a lot of people think that implementation is something that happens when a product is literally available after 20 years, let's say, and that's really the wrong time to start thinking about implementation. So, but yeah, in theory, it's about how you can make it work in practice. But my point of view on that is that it should start from the very beginning.
Yeah, I agree.
And that's really difficult. It's
Most people forget that.
yeah. It's also difficult because you have to get people, resources, do things in the beginning, which people don't often want to lose time on.
Yeah.
Do you have some examples of ones that have either done that well, or maybe that definitely did not do it well, just to help us?
Just to give you an example, like most of you know electronic medical records, they are not developed by patients or by care professionals. They are developed by corporate organizations who want to solve a problem, and it solves mainly the management of the hospital's problem. It doesn't solve the people who use it necessarily. It doesn't solve it. So that's why you have all these people using it, complaining, and frustration. And so there is, in my opinion, it's a complete failure of healthcare innovation.
Professor?
My opinion, it's not like
The EMR, how long has that been widely available in the Netherlands?
I don't know.
What like how many
Chipsoft,
years?
I think, was one of the first.
2003,
Yeah.
I worked in an organization and we were one of the first to
Yeah.
have an EPD
Okay.
system. Yeah.
And I say this because we've had it for a little bit of time as well, and it has had its bumps in the road. Like it hasn't been fully. Well, I think now it's widely available and widespread, but over the years, the companies that have done the best are the ones that are able to change the process to be able to take into consideration the providers that are actively using it. So they're able to adjust it to make it more appropriate for those that are using it every day. Like you said, that there might be a gap there currently.
Okay, well, yeah, there are gaps currently, but it's set. So the dominant, it's a monopoly. So you have Chipsoft in the Netherlands. You have Epic, I think, is
Epic is here too?
no, Epic is good. Yeah.
Okay. Oh, so
They have a small share, I think, in the Netherlands.
So Epic is one of the biggest right now, the biggest and most costly,
Yeah.
most expensive because of how it can be scaled in so many different ways to provider preference and user.
We have two that are 80% of the market or something, Epic and Cerner are the
Epic
most
and
market.
Cerner is another one that has really opened up the sourcing of it and allowing others to design it how it best fits their organization.
Mm-hmm.
And whereas Epic is more rigid in its design, right?
No, they're big.
Okay.
They can, yeah.
Historically.
Other ones were very, this is the way it is, you can't change anything. And what happened is they started losing clients.
Yeah,
and customers.
so but I think that's really the benefit of having multiple players in the market. Because in the Netherlands, even though Chipsoft is Dutch, it's really not fit for every user. Okay, it fits very well probably for the managers.
Yeah. The ones that decided to buy it.
Yeah, because you can pull a lot of administrative data from it. It's like I heard in the back of the sideways. I kind of got that from a doctor in the business medicine. But so I think the main problem there is that it works well as a standard solution, and it's one of the solutions that it's not easily adaptable to the needs of the particular hospitals or people.
Yeah.
So what you get then is you get a whole host of innovations trying to repair something that was initially already set up for you.
Yeah.
So I don't know if you heard of all these things like, oh, now we want to have AI who who will translate what we say into the electronic medical record to make everything that goes wrong into electronic medical records repair. So you have all these new innovations now trying to repair what's wrong with electronic medical records. So it's really, I think, it's definitely a big challenge.
So we should never use the user-centered design, because then that would preclude future innovations to fix problems, creating revenue for somebody.
No, I mean user-centered design is
I'm being very facetious.
But user-centered design is good, but it depends on who you decide to be the user, right? If the user is your manager, then you will get an entirely different system. If your user is a patient, if your user is a clinician, informal caregiver, nurse, depends on who you.
Well, as far as making life easier for the people on the ground, right, on the front lines trying to make this work, in the stroke service, this has been a lot of what you've tried to do, and inter-organizational. Do you have any examples of things you've done to try to make that process flow okay? You do.
Yeah, we do. We invested 10 years ago a lot of money in the central hub, and to connect all the software systems from all the 17 organizations, and it failed.
Well, and we were having a little bit of a sidebar earlier about value-based care, and we love this idea, but sometimes something doesn't work. What were the key lessons learned?
We had Chipsoft, and 4 hospitals tried to use that software system, but the one had, Maastad, for example, had version 1.0, then Ikazen had 1.1, and of course Erasmus Medical Center had gold. Okay, now we are going to interconnect. No, it weren't the same systems. So we tried everything with other partners in Rotterdam, Rijnmond Net, to create a central hub. And then of course we had the AVG and the privacy laws, and then we stopped the project.
So technical barriers and
human barriers. Just people like
the privacy, is that GDPR?
Yeah, GDPR.
Okay.
Oh, in the States.
Yeah.
Well, and that's a concern. We've talked about that in the US, and honestly, since our talk 2 years ago, more than 2 years ago, I've shared with students as we talk about different country systems that a problem I heard here that we have in a different and I think lesser degree in the US. I'll get my American practitioner friends to chime in, but the ability to share information, the technical part, but then also the legal part, because if you've got well-intended privacy regulations impeding the ability to coordinate care between organizations, that's a problem for the consumer-centered design, it's a problem for practitioners, it's a problem for the government system. Does this ever come up in the ministry about trying to fix this problem so we can coordinate care?
Yes, a lot. In our program now we have actually 3 lines. One is shared decision making, but my colleague is really focused on the digital and the ICT and how we can help hospitals to also use the prompts that I talked about earlier in the EPD system, how we can connect that. So we also have a department ICT within the ministry, and my colleague, she's really trying to figure out how to connect that and how to really look at the zips, the zorginformatiebouwstenen, those are like parts of the data, how to use a standard system to share information and to connect information and to actually use that outcome information within practice to actually endorse shared decision making. So it's actually connected with it. You have shared decision making as a process, the skills, the competencies as a healthcare professional, but you also can use information if you know. Maybe I can give a little background. From our program, we have developed 33 sets regarding different diseases. So, for example, knee arthrosis or breast cancer, and those are really outcome sets that healthcare professionals can use. That okay, if you decide to go for a certain treatment, these are the basic outcome values that you can get, and that really helps patients to decide. With a patient like me dashboard, for example. It helps you decide which treatment you want to choose based on your own values and preferences. So you have patients like me data that have been created, dashboards that have been created, but a lot of hospitals are really struggling to use it because of the ICT challenge. So
That's that integrated care team, ICT? ICT?
ICT, it's the information
IT.
part. Yeah.
Communication.
IT.
Oh,
IT. So it's a really huge program that we have started, and its focus is on implementation, but we need IT as well.
So help me understand, I'm hearing, what I interpreted from what you said was like the shared decision making between me, the patient,
Yeah.
and my doctor at this clinic or at this hospital. But what about when he needs to coordinate my care with a different entity and they need to share information, my personal health information, in the US we call it PHI, protected health information, personal health information. And maybe, and you and I talked about this before, Bianca, we have to also talk about the money. If they're sharing the same, I don't know, €1,000 per quarter or something for my care, they need to be able to talk about all this stuff.
Yeah.
And I know we said historically that was a challenge. Like in the stroke network between specialists, hospital, GPs, physiotherapists, even home care.
Yeah.
Is there a path to making it easier from a regulatory perspective?
Well, choose one standard form, I think, but that's really difficult to force because there's a free market.
Yeah.
So, and that's really, from the law perspective, it's really hard to force hospitals to choose one standard format concerning IT. So that's what makes it difficult. Yeah. But we are trying to in the program, at least for the hospitals that participate in the program, because we cannot force them to participate. So it's on voluntary basis that we provide as much IT support as we can, and that they can share information as well among each other, but also use that information, what I refer to patients like me data, in their own hospital, and how that can be connected with the EPD, with the electronic patient files.
Thoughts about how this looks from your side on the clinic?
Yeah, I do have some thoughts. I think, sure, IT is an issue for sure. Different versions, different venturing programs that don't communicate well together. I also think privacy legislation is a huge issue, which prohibits people from sharing data with each other, even if it's in the best interest of the patient. And I won't go too deep into how it usually goes in practice, because I mean, especially in acute patients at the emergency department, you don't have the time to get the appropriate consent for acquiring information. But how it usually goes, for example, if I get a patient at the emergency department and they are known at the Maastad Hospital, I work at the Erasmus MC, I have to go through a call center, I have to wait, I have to get an attending that also doesn't know the patient, who has to go into the patient file, they have to look up the data, like what's the past history, what medication do they use, and then they say, oh, they're also known in that hospital, that's where they got the pacemaker, and you have to call that hospital, what pacemaker is it MRI compatible, that kind of stuff, and it takes up a lot of time that you could better spend taking care
Will
of
they
the
answer
patients.
those questions? Do you need special legal forms to be able to get the answers for that?
I mean, how shall I answer that? I think you would need consent, but if you do it in the for the best of the patient, then they will share that information with you. How legal it is in that moment, I'm not entirely sure. But that's the only way to make it workable, even though it's still not time efficient. But otherwise, you couldn't treat your patients appropriately. For example, contraindications, what we talked about yesterday.
From maybe a government perspective, what would you need? Like, how can we support that? Because we're also struggling to find out how to support hospitals as well.
I think one of the things is, of course, we have the European legislation now, the GDPR, and I know that the national government probably doesn't have a whole lot of influence. Like, it goes over so many different schade, how do you say it?
Levels.
Levels.
Yeah, exactly.
Yeah.
Different levels. I think the most important thing is when developing these acts, you also get the opinion of the people that it affects in the hospitals, for example. Today I read an article about the EU AI Act that has been voted in by Parliament. I'm not really sure how many stakeholders have been involved in the development of this act, even though it's very impactful for not only us as clinicians, but also us as researchers.
Yeah.
So I'm keen to hear what it will be about, but at this point I'm totally clueless how it's going to affect my daily practice.
Yeah, that's I think one of the things that when I did my PhD, I thought, okay, research, you can use that as the reasoning why people do the things that they do and decisions that they take. But unfortunately, and I've come in an area where it's not that leading always, because it's a political sensitive environment as well, and there's a lot of complexity apart from just the data that is bearing out. So I completely understand your point of view, yes.
But I don't think it'll be a problem we can solve here tonight.
We're talking about problems.
Just maybe to give you some Belgian perspective, because they are experts in finding the middle ground somewhere, which is often in a dodgy way and not efficient. But so we have, I don't know how it's possible, but we have a national health electronic record database. And it only consists of things that you allow to be there. And I also don't know
Who's you, the patient?
Yeah,
allows?
you think you allow it? Yeah.
Or the provider, or both?
No, it's definitely you have to consent to that. And then, I know that this was very used a lot during COVID time. I don't know if the Netherlands had some kind of national thing similar like that. But it was like your COVID test would be available nationally, so any doctor would be able to access it there. But it can actually be used for many more things. It would be like, obviously, this was going back to the discussion of the National Electronic Medical Record, but that never happened in any country, I think. But it's still something that remains in Belgium. So maybe the middle ground is finding some kind of database that can be used for something. Not everything, but maybe something that can be easily accessible.
So like crucial information.
Yeah, maybe something like a medical emergency.
Without essentially forcing all the providers to use one EMR.
Well, it's definitely not related to the EMR. It's like, I don't know what's on the back end, what kind of software it is, but it's something that you can access. So maybe it can be pulled into the local hospital data, but right now every care professional can access it just by logging in as a care professional. They have access to the data of the patient.
So if you went to your physician and had a COVID test and it was negative or positive, that provider would put it into the system.
Yeah.
So it would indicate that you are COVID negative.
Yeah.
For example.
Yeah.
Until the next time you're tested or whatever, then it would update it but every provider had access to that system, you're saying, to be able to log in.
Yeah.
And was any health providers that could access the data?
Yeah, I'm because I'm not a health provider myself. I would have to ask my wife, but I think the hospital uploaded it. Somebody there uploaded it, so they had access to that.
We have EVM.
What is that?
Yeah, that's an organization that can see all the things all your vaccinations and all your
Institute of Public Health and Environment.
So we have that.
Yeah, we have that.
Another thing that's been used in the US, and I'll look at my American colleagues, do you know about any of the regional information exchanges, RIOs, and these other things? Do y'all talk about that? So without forcing the providers, and I'm not a technologist, but there are some common file interface protocols that can be used so that you can share to a common hub, a repository within a region or metro area. So these exist.
Yeah.
Maybe that would be a path that might be useful.
Yeah, we tried that in Rotterdam.
Okay.
Yeah, but we failed.
And that UAB does it with our affiliates, like with all of our affiliate sites or our managed sites, but you have to have a certain an ADT feed set up, so you have to have an admission, discharge, transfer feed set up, and that there's a lot that goes into that with coordinating with our IT team and their IT team, and we also have to have the same type of like interfacing like on our side that where our physicians log in and then where their physicians log in.
And it's not the same Cerner system, it's something separate.
Right.
Was there a certain like mandatory reported diseases and stuff that
But those are registries, right? They're a separate thing.
yeah, but I don't even know who all has access to that, but it should be public record. Do you know?
No,
And that's different than Ruben being able to share all my test results and his notes from my exam and all my hospitalization records when I, go for the weekend up to Friesland, right? Because we're gonna hang out.
There is
Milk some cows or something. We learned about the Friesland cows today, so we're very excited.
that's great. Apart from the cows, there is also
Those two.
He's shooting squirrels. Okay, that's not forgivable. So
Alabama.
squirrel is our family. It's our family animal. So okay, but I was just gonna say a bit separate from this inside health system discussion. You have outside health technology, like I have on my phone now emergency contacts. So that's another route that potentially will grow into this thing, is that you will be able to share directly with your care professional. Just, I don't know, maybe you will come to the doctor and say like, here's my data plan. So that's another route. Yeah. So, but that's, I don't know how that's going to evolve. That's going to depend on.
Well, this exists in some countries.
Yeah, and that's also.
So,
Yeah.
did you have?
I have a personal health environment. So next Friday I'm going to a doctor and I can show him, okay, this is my environment. What do you need? And he can.
They don't pull it into their system.
No, they don't. I'm not sure.
Do you just show them your phone or something? I mean, help me understand.
A pharmacist is entering data, my GP, my hospital. So it's, and I had consented to show that.
Is that een PGO?
Yeah,
PGO.
yeah.
Does that provide, so that sounds like it provides the level of information that any given clinician or insurance company would need to coordinate care?
But is it only in primary care, the healthcare professionals that are working in primary care that are connected to PGO? Right?
Yeah,
Not
yes.
secondary care, not.
I've never heard of this before, so all I know is that I don't try to look into these things when I get a patient in the EDs.
Yeah.
But I think it's only primary.
It's only primary care.
I guess.
Is there not a loophole like for our ED, like we can pull or get patient information without their consent because it's an emergency? We don't need their consent. Is that stands here as well?
Only for like your own hospital's electronic records, but I can't look into the GP's records or another hospital's records in emergency. You just can't access that
That's
information.
a technical barrier, not
Yeah,
a policy.
Right.
Yeah. Oh, like
So,
yeah.
So do you just
either.
like request it? You just have to request it.
So it sounds like you were saying that as a physician, you are the person that is requesting those records if a patient comes in. So I worked as a secretary in the emergency department at UAB, and I was the person that had to request those records. And I have a big directory of all of the hospitals in the area that could possibly transfer patients to us, and I have to call their medical record office and say know enough about the patient to say this is how far back we need their history, this is the images that we need, the lab results that we need, and then they have to fax it over to us, so we have to wait for that whole paper record to come
That's
in.
crazy.
Yeah, so in the inpatient clinic, that's how we do it as well, or by mail or some other method with patient consent. But at the emergency department, when things are time sensitive, you don't really have the time to ask like a secretary to go do that and call another secretary. That's quite time consuming.
Do you find yourself just running the tests? Like,
Is that what it said?
Sometimes you need real-time tests anyway, so what's the situation like right now? Or just calling other physicians elsewhere for a real-time relay by telephone of the most important data. That's usually how it goes.
What if it's a transfer from a smaller hospital? Because you're at Erasmus, right?
Yeah.
So if you get somebody from a small hospital and they already did a CT scan maybe, are you going to redo that, or do they?
No, they'll write a letter usually, which will also be sent to the GP, and they'll print it out and send it along with the paramedics who hand it over to us so we can read it.
yeah, we do that as well. We print everything out. We transfer with a file this thick. It usually has a disc with the images of whatever. Put it all in a packet and send it to the patient.
Is that how you send images that way on a disc?
We've since a couple of years we have service for that. So someone from the radiology department has to upload it to a server, and then we can download it from the server, and then we can access the images.
Like the PACS system.
Yeah, exactly.
Some hospitals have it and some hospitals don't.
We have packs and we have dirty packs.
Yeah, that's normally how it goes.
Dirty packs is like, so packs is like if the hospital that is sending us a patient is already connected with us, then they can like send those over without a disc. But dirty packs is like they send me a disc, I have to upload the disc, and then it goes into like essentially a separate type of area. Yeah.
How long does that take?
Depends on how much is on the disc.
Well, if you are, so from an oncology point of view, so normally what I don't know how it is now, but in a while ago you had to, because it's a chronic disease that spans across different years, you've been to many different care providers. I know that some people would have, I did it in the past, but you often had to keep track of all that information yourself in the end, because you're the only one that will have a full overview of what actually happened to yourself. Because a physician would then ask you like, okay, you come to a physician, but there's often no one that would have. Maybe that's changed now, but it's very difficult to get a full overview of your complete medical history. I don't know, maybe that's changed now. Maybe better.
Doesn't change.
No.
I have patients who have printed all the information and carried it in the bag to the hospital.
Yeah, so I think it should be the general practitioner here who has access to all the data. So whenever you're, for example, being treated by an oncologist, then they will send letters or updates to the general practitioner at set times, usually once a year or more often if necessary. But any communication is always going to be an excerpt, of course, from what happened. Like they won't send all the images, the scans. It's just a letter with a summary of the most important things.
And they forgot a lot.
Sorry?
They forgot a lot. When you make a call to the GP with the last information of your patient, they didn't know.
What about the insurer? Aren't they the hub? They're paying for all of this, so don't they have all this information?
No, but you know with your insurers to see your medical data, like it's quite sensitive, of course, so the insurers can't see.
They know that I have XYZ procedure, but they don't know what the results of the test or the procedure were. Was that?
So
They're not really sure to what level they can see. Like, I don't think they know diagnosis, for example. They would know hospital admissions probably, but I'm not really
So
sure.
they pay a bill without knowing why I was there? They don't have my.
They won't get an exact specification. Maybe you can tell more about it.
They have claims data, and we work with they would say diagnosis treatment combinations, so they would know the diagnosis and they would know the treatment, but maybe the results of the treatment. They don't know the exact EMR data. They don't know. It's just they get fed the claims data, and then might want to follow up on certain claims data if they have a suspicion of fraud, for example. But there's no really sensitive medical information that goes and flows to the insured.
We had this, you know, before academia, I was on the insurance side. Don't hate me. But one of the challenges we had is we would know that a procedure happened or an office visit, and we would know the diagnosis, at least the presentation diagnosis, right? That was the driver of the encounter.
Yeah.
But we didn't know for important things like labs underneath it. So if you're diabetic, I can't know what your A1C is. I can just know that you got tested.
Yeah.
For example, with the claims data. But that has since changed. And so now predominantly the insurers are all getting a data feed that give them those labs so that they can help manage the diabetic, for example.
Yeah.
So are you saying that in the Netherlands, the insurer doesn't have, in this example, the labs so they can help manage? They just know this is a diabetic, they went to the doctor.
No, and I think they don't necessarily want to manage. They're just sticking to insuring the care, purchasing the care, but they are still, I think, stuck in that bookkeeper role and not necessarily wanting to orchestrate the healthcare landscape. Selective contracting is another example that's not coming off the ground. They're quite passive in that sense in wanting to design how the healthcare system should look like.
And I think another question is whether you would want them to have that responsibility, because it's a huge conflict of interest probably if they have to pay for care and they also get to have a say in how it is designed and what care you should receive.
Yeah.
I'm not sure if you want to
And that's
get that intertwined.
that's their leverage in the US. It's because they pay for care, they need to have input in where you can go and when you can go, essentially. They have a gatekeeper.
Well, then, okay, so I'll be the devil's advocate then, or
Sure.
maybe literally about insurers, because even in the US, everybody hates insurers. But I worked for them. Now the ones that I worked for were physician owned, so maybe it makes me less detestable than
No,
other
not
ones.
at all.
But I'm just thinking about, and we were a managed care organization insurer, so we were literally trying to play our part more than just the physicians could do by themselves, especially because they don't have all the coordinated data. So you, as you said, you don't know what happened at the GP, and the GP doesn't know what happened in your clinic or at another town in their clinic. If they're diabetic, you don't necessarily know whether they're filling all their prescriptions or getting their foot examinations or testing their A1C, and if the testing is it good, unless they were inside the four walls of your clinic. So that was a role we were trying to play, but we were able to get the data to know, okay, is quality care being provided? And I'm glad you opened the door to talk about PROMs and PREMs. And so can you, I think maybe both of you talk a little bit about what are some initiatives to ensure that as the purchaser, we're also getting quality care purchased?
Yeah, well, there is of course this movement of outcome-based care and value-based care, but I think insurers are fed certain quality indicators, so they can get quality indicators from hospitals, but steering on that information and purchasing based on that information, that's still a future scenario. So there is of course some thresholds or some benchmarks that maybe insurers want to hold on to providers, like you have to score like this or like this maybe, and then you maybe get a bonus or we will contract more care with you, but that's it. I think that's it. But there's no short-term quality feedback. There's no short-term quality incentives. That's what we're trying to do, but it's not working out.
Because if I'm an insurer and Ruben's clinic is providing higher quality care per an outcome measure or an experience measure or both, then Phil's clinic in Las Vegas, we know your doctors are all out in slot machines, they're busy. Then, but you're telling me I can't make that I don't have the information to make that kind of informed decision now about which one is providing better quality care so that I can pay him more, or steer more patient volume to one versus the other?
Yeah, there are proxies, so there is outcome information, but
I think
for certain conditions, not for all conditions.
information goes to the IGA, right? Inspection. The inspection, yeah. I think that's the place where those outcome data probably should be, right? Because they supervise whether appropriate care is given at places they're responsible
It's
for.
a central agency.
Yeah, government agency.
Inspection agency, yes, but the role of the insurance is really in child shoes and it's also not involved in our program right now. The insurer organization represents all insurances in the Netherlands, so we really focus now on how we can implement the prompts, everything that we have developed concerning sets in the past 4 years now, how we can get that into the hospitals and how we can really promote shared decision making. So our focus is really content wise and not in that sense insurance and what their package concerns and what they can buy regarding quality.
What about the new government who has this grand vision of integrating everything? The integraal platform or
Yeah, so our housing-based program is actually part of the ISA, the integrated,
I don't know how you call it.
It's a Frans yeah.
So it's not.
It's a weird term for it. I don't know how to say it in English, but so one of the
care policy.
So one of the goals is actually how to implement shared decision making in a medical specialist sector, and that's actually the reason why this program has emerged and has developed, and now is really focused in the second phase on to implement and also help hospitals. So I'm really looking forward to have that talk with you later on, maybe. Yeah, so that's the basis of this program.
But the insurers are not involved.
No, not in this phase. No.
So I'm wondering if in the future if the government wants to see the insurers maybe do something more than they're doing now.
Maybe in the future, but I think the focus now is really to really implement the sets that we have developed for specific diseases regarding outcomes, so the prompts that we've developed.
Mm-hmm.
So it's really focused on competencies of healthcare professionals, on helping hospitals to actually use that mindset, because it's a cultural change also.
Yeah.
And also we have involved the FMS, so the Organization for Medical Specialists, and also the VNPN, so also the organization that represents the nurses. So we're really now involved in that with those kind of parties to bring out phase 2. So that's really the focus. So maybe somewhere in the future, but at this moment, no.
But what are you gonna do when you know all the prompts?
Well, you actually want to use that in the hospitals. You want to use that information to support and endorse shared decision making. So you have two types of shared decision making. Actually, you have the general process, just the conversation, just the skill to do it, which is already a huge thing, I think, a huge cultural change, especially for physicians. But I think apart from that, you can also use that data that comes from the prompt on individual basis and on patients like me basis. And you can use that to actually give more, I think, background information for the patients to make decisions that suits and stimulates person-centered care as well.
But so you want to give it to patients, or you want to give it to care professionals, or I mean, so I collect my prompts. I know what happens and what doesn't happen.
Yeah.
And then
And you want your healthcare professional to also get it into the system, ideally,
uh-huh.
to use that. And then based on that, you can have that conversation, shared decision making. So it's actually a tool that aids shared decision making. Because you are asking the questions, you address those questions that are important regarding quality of life, right?
Yeah.
So it's a tool.
Yeah. But it's nothing to do with the discussion we had about quality of care. That's like on a more macro level. You wouldn't give
It's more macro.
Okay.
Yeah.
Okay, so I'm going to be an insurer again. So, okay. So
Here we go.
Yeah.
Why didn't you invite me? You wanted to invite me.
Sure.
Didn't you find somebody to? You
Well, I
wanted
think they were intimidated by
Yeah.
what I do.
Yeah.
They said, you can't walk into the wolves' den, you know.
Okay.
But, you know what?
Can't take
But,
insurance out of the boy.
So I want to come back around to value, so I'm going to call on our value PhD dissertation person over here in a minute, but I usually give a heads up, don't I? Usually.
Sometimes.
So, yes, I care about shared decision making. It makes me feel warm and fuzzy inside because the patient gets consulted and involved. But I'm just going to be a cynic. If they don't get a good result or bring down the cost of care, so what, right? I'm putting on I'm acting, right? I'm putting on a hat of the cynic. But if the patient is involved, but it doesn't make the health outcome better, or the health of the population better, or the cost of care better, is it just nice, or is this a solution? Is this a key problem we're solving?
I think autonomy is a very important aspect in healthcare in general. So even if you don't really improve outcomes, then just that factor is already making it worthwhile to get more involved.
Ethics?
Yeah.
Oh yeah.
Oh, but I'm an insurer. I don't have to worry about it. I'm joking.
joking.
I also think one of the options that we forget is the option not to treat. And shared decision making is really also endorsing that as well. So you don't only focus on what is there to choose, but there's also an option not to choose for a treatment. So I feel like it's person-centered care, it's autonomy, it's the basic of life, quality of life.
Can I challenge that? So I know from care professionals, with all respect to the good care professionals,
different care.
there are also financial incentives. So I know the patient, he is 80 years old, he just had major problems, but his family still thinks it's a good idea to treat him. And I think, okay, probably not the best thing to do, but so what? I will get more money, so I'll just treat him. So, so the question is also like, the bigger picture is also the financial incentive here, because you can still decide and talk about it, but if financially you still get incentivized to treat.
Yeah, that's true.
So
we have this problem.
If you
can help us with this is one where I want your input because we have this problem, and you're helping us if you can help us get any ideas, because we're putting knees and hips and heart valves in 85-year-olds. Am I wrong? You all see this? Yeah. Because my cynical side will, like Peter says, because we get paid to do it. And as you said, maybe we didn't really ask the family or have that robust discussion with the patient.
Sometimes even the family wants it.
Yes.
And then you're the only one standing between the societal cost and everything that's bad for the patient, and everybody else is saying, do it.
Because we're not emotionally ready to lose mom.
Yeah, for instance.
Yeah. And I think that plays a bigger role than the financial incentives that the physician experience. Because no physician wakes up in the morning, I'm going to make a lot of money. It's not
to do.
Maybe in the USA, maybe some Dutch physicians as well, but I think the most physicians, and even the ones that are not salaried, they don't wake up with that feeling, and they don't really feel that on an individual level. I think they might feel it on like the physician group level or the medical specialist enterprise level, that they have conversations about it. Okay, we are compared with other medical specialist enterprises around the country. We have to really perform in order to get to a benchmark or a threshold to get the revenue we got last year. So to point the finger at individual physicians is not fair, and to point the finger at medical specialist enterprises is maybe a bit fairer, but yeah, I think talking about those financial incentives that physicians experience distracts the discussion from like shared decision making, where you want to talk about. And the financial incentives, there have been some studies about it in the Netherlands, but they're not very strong. There's not a lot of evidence on that. but yeah, we are in this rat race where we have to produce more to keep up with other, so we're keeping each other busy. It's the same for us scientists. We have to publish, we have to publish, we have to publish. So it's the same. It's the same, and you can't blame the individual physician. And I think it's also not a solution. Maybe it's a solution to make every physician salaried in the Netherlands, but then there's people that say, okay, we had those waiting queues before we had the health reform, and we might want to avoid having those waiting queues.
Is there discussion or experimentation around any kind of value-based experimentation to help align that person's intrinsic motivation, the physician's right to do the right thing for patients, with their ability to do it in practice?
Yeah, I think so, and I think the stroke service is one of those examples that tried it, and I don't know what the current results are, because you're still piloting, right? Or is it?
The project ended.
Yeah. Well, we've
But
also.
we have a good example in, for example, in Uden, a hospital in Brabant. That's an area in the Netherlands. And they had those enterprises, those medic enterprises, and they stopped that, and they gave them a salary, a good salary. But the last thing I know, that project failed as well.
Yeah, and that project failed not because the physicians got salary, but that project failed because
The healthcare insurers.
the healthcare insurers. So they had certain contracts with health insurers. I think one or two. They had
2 and 3 years contracts.
Yeah.
And that is not sustainable for the future.
No, and it's not sustainable. And they also started or stopped actually registering certain types of care. So we get the money anyway. So why do we have to register any? And when you have this contract with 2 insurers, that's no problem. But when you have this contract, that's a problem. But if you have this contract with 8, with all insurers, that's no problem because you get the lump sum. But if you have this culture of not typing down what you do, not claiming the care you have provided, there's no claims going out to the insurers which did not have the lump sum contract. So then you're missing out. And they also invested heavily in managerial staff.
So they were documenting less because the documentation wasn't required to be paid.
Exactly, for those 2 insurers.
But then that behavior spread to all of their.
Yeah, that's what I heard about it. So that, might have played into failure.
Yeah, and the contracts. So they offered a 2 or 3 year contract, but that's not sustainable for the future. You need 5-year contracts or maybe 10-year contracts.
To make a sustainable transition, 2 or 3 years is not enough. It's 5 or 10 years, what you're talking about.
One of your colleagues came up with that question in the last couple of days, right? How long are the contracts? We heard it took a long time to come up with a value-based contract.
Normally 1 year. Our contracts with healthcare insurers are normally 1 year. So every year in October you are sitting down with the healthcare insurer, all the healthcare insurers, and you talk about the money. Every year.
And it was effective January 1st?
Yeah.
Calendar year.
Yeah.
But if you designed it well to begin with and all the stakeholders were there, ideally you don't need to do much adjustment, right?
Are you seeing reimbursements going down?
Yeah.
And costs are going up?
Sometimes, for example, for geriatric rehabilitation, its reimbursements are going down. On basis of indicators, they say indicators like quality of life, we measure that for admission time. So I said, okay, so you need me to steer on admission time, that's no problem. Even if you're not well, even if you're not well treated, I throw you out in 4 weeks. Yeah. That's easy, but that's not quality of care. But how does a patient knows what quality of care is?
I think most patients don't know.
Really, I have a stroke.
Yeah.
No, that's not a good example.
You have the best.
Yeah.
Well, I'll give you an example. Very
I
good.
have Parkinson's disease. I go
Yeah.
to the doctor, go to the hospital, and then they say, we have the best treatment you can get. How do I know if that is the best treatment?
You know your experience, was it positive or negative? But yeah, we always joke that the surgeons are the most rude people, or that you want the rudest, most egocentric surgeon rather than the nice one. In my own extended family, so I had a family member who had to get, she had breast cancer, and so she needed surgery. And she went on and on about how much she loved the surgeon, how nice the surgeon was, and the bedside manner was wonderful. But the results were not great. There were side effects and things. And so she referred her own mother to the same surgeon, who also had some of these side effects and now just went for revision surgery yesterday with a different surgeon, who I think is not nice, but much more skilled. And so what matters, and that underscores your point that I think most patients have an impression, but that doesn't mean it's about what we would consider quality necessarily. Maybe there's shared decision making, maybe, but unlike other markets, we don't know enough to make ideal decisions in healthcare, we the consumers.
Yeah, I think it's really subjective because a lot of patients focus really on the relationship with their physician instead of really how treatment is explained, how it is executed, and the consequences aligned to it. I think like for a patient it's really difficult.
Isn't that normal? I mean, if you go to, this is a probably super simple example, but if you go to buy a car, you probably don't know what the car is, right? I mean, none of us are automotive engineers, so you just trust this guy who's selling his car to you. So, if I go to a doctor, trust is one of the most important things for me, and I wouldn't know how to judge his quality skills. I think that's normal.
But also important is the relationship, what you feel when you come inside by a doctor. And,
Yeah.
When I come inside by my GP, and I think, oh, I'm all for him, and it's over.
Yeah.
You won't tell my story.
Yeah.
I also think it's
They
patient.
can tell me everything to do, but I don't do it.
Yeah.
I also think one outcome doesn't say anything about quality of care because, for example, with the surgeon that you mentioned, every surgeon is going to get complications, but for one patient you're going to have a good outcome or a bad outcome, but that's not necessarily saying anything about the process or the quality of care being given. Despite you having had a bad experience, the care might have been just fine. It's hard to say.
And I was saying the opposite. In her case, she would have rated the surgeon very highly.
Yeah.
I don't know, on a more objective measure of quality, to my knowledge, she didn't do any research to look at the STARS measures or any other kind of scores for this.
Patient rates.
Probably not. She met her and had a good qualitative experience and felt trustful. Is the person, maybe the surgeon is wonderful, I don't know that. It's a little small town, volumes can't be that high relative, so I was skeptical just based on the setting.
I have shared decision making with my GP. I come in and he said, "What do you think you have?" And I said, "I think I have that, and that, and I think I need that prescription." And then he said, "Okay, I agree."
No, he says, wait, that's too expensive, that's too expensive. Okay, that's fine, let's do that.
Are you sure you don't want 20 more like that? No, just kidding, that's not.
Artson's already showed us a video of a comedian who's joking about, Dutch physicians in the primary care, they just give you paracetamol even though you have a gunshot wound and they say you go. Did you see this video? It's very funny.
It's true. And about the jokes of the American gunshot wounds.
Yes.
We have gunshot wounds.
Oh, well,
We would never go in with a gunshot.
The emergency room at my previous school's hospital was joking, called the Knife and Gun Club because they were the most popular for taking the severe. I mean, we had military surgeons, who were working in Iraq, Afghanistan, and they found it to be very good training to work in that particular emergency department. And it is because we're very good at those kinds of things.
That brings up good. What are some of the things that you've heard about the U.S. healthcare system or the state of Alabama that we can answer for?
We are number one. Number one in heart
The
disease,
magnet
hypertension,
hospital.
diabetes.
Magnet hospitals?
I visited few magnet
Oh, okay.
hospitals and I love them.
Yeah.
Yeah.
Okay, good.
Great.
Where did you go? The
When?
Magnet Hospital?
Yeah.
2007, New York.
Okay, okay.
Yeah.
Can you tell us a bit
Great.
more about what was so special about?
They are very good for their professionals, for the nurses. So they have 14 criteria which involve nursing, and they give good salary. They keep them healthy by also kind of things in the hospital. They can relax, yoga, that sort of things.
Patient to nurse ratios and
Yeah.
a better balance,
Yeah, better
more
balance.
reasonable.
Do they still require a master's
Mortality
degree
is
training?
lower than in other hospitals, in magnet hospitals, so patient outcomes are better.
And all the nurses are bachelor trained at Magnets? Okay.
Well, yeah.
Yeah.
Jen, as a nurse, did you work in a magnet hospital?
I've worked in both the magnet and non-magnet.
And you
I personally can tell the difference. I've had other nurse colleagues who they are like, oh no, it doesn't matter, just it's based on the management. But the magnet hospital that I was in, I was one of the assistant nurse managers. And so it was really cool to be a part of our magnet recertification as an assistant nurse manager because we talked a lot about like succession planning and all like just so much about it. And they interviewed a lot of the staff about how they feel about management and how they feel about working there. I mean, they come in and they do all of that stuff because it's really important to be a magnet hospital. Your employees have to enjoy working there.
Yeah.
And it makes a difference on the quality of care that's provided, in my experience.
Do you have
I
any?
agree. We do it also in our organization. We started last year with the, it's not named the magnet program, but the, hoe zeg je dat? De involving. De
Criteria.
De criteria ABC. Ja. And
that's an optional certification
Yeah.
organization can pursue, or it's required?
inquired.
Which?
So did you say that?
So
I asked if these criteria are required or is it an option?
It's an option.
Okay.
And they started a discussion with the nurses and the volunteers how to make them satisfied in the organization. What's good, where you're good in, where you are the best in, and what you can teach to the others, and that sort of thing. Yeah. And that makes you proud of your profession. Yeah.
Proud as a peacock.
Okay, I think a lot of hospitals could learn from that because I've heard from so many problems with this is probably not to do with and this is quite a complex problem, but I know that care professionals have sometimes really difficulties to work with each other.
Yeah.
So I think if the hospital would maybe recruit in a more better way and support the staff in a better way, maybe could make a big difference probably.
That is why I'm doing what I'm doing. So that's why I decided to go back and get my master's degree in healthcare administration because I worked on the front line as a nurse, before the pandemic and during the pandemic, and then, so many things happened and there were so many challenges, and I worked in a lot of different hospitals in the States, and there's so many times that I'm like the management, they just don't get it. They just don't get it, and so all these decisions were being made, and like basically forced upon us, and I'm like that you're slowing me down, like you're impeding my work, and so I figured, the best way to solve that problem is to join them and see, what I can do to be a part of the solution to that problem. As somebody with frontline experience, hey, this is how your frontline is gonna interpret this decision that you're making.
Mm-hmm.
But how are employees involved in those kind of decision making? Because in the Netherlands, I know there's the VAR and the PAR, so the nurse advisory board and the patient advisory board, so they can give their input for certain decisions that affect them and their work.
So for me, from my experience, it really depends on the organization that you're working in.
Yeah.
Because that's not a mandatory thing. There are some organizations that have that. They have a patient advisory board where members of the community come in and contribute to decisions that are being made. And the Magnet Hospital, that's another part of the Magnet program that I really enjoyed, was we had committees that we would go and be able to be a part of the decision-making process. And that was really important, and it the better patient outcomes, which is the whole point of why we're doing what we're doing.
So I know for-profit hospitals is a foreign thing here, but even I worked in a few for-profit hospitals, and we had patient advisory committees, and I reviewed. I believe it's over here as well. That the Joint Commission hospitals become Joint Commission accredited, or no? Okay. I know it's an international accreditation body, so they also have not necessarily.
De Santion ziekenhuis.
Oh, Santion. Oh, ja.
Santion.
Ja, is dat 5 of 6?
Nee, het zijn er meer.
7?
10 hospitals in Santion.
10? Oh, 10.
Yeah. The joint.
The Joint Commission.
Yeah,
Because, that is one where if you receive federal dollars, which you have to as a hospital, or you do not typically last long because of the Medicare is such a big payer. You must be Joint Commissions accredited. There is another one that is up and coming, but Joint Commissions kind of has most of the market share for it. Hey, where was I going? Oh, they have a list of requirements, but also suggestions for hospitals. So even for-profits will embrace things that you may not see from a typical for-profit company. So it's kind of nice to have that. We don't like doing commission surveys. You know, everyone is, it's really spooked about it, but I think they also do push the standard higher for all hospitals to some extent.
Yes.
So.
Okay.
Does anyone else want something to drink?
Other things you've heard about the U.S. system, impressions, rumors that we're always interested to share.
Did you get something else to drink? No? Okay. Enjoy your meal.
What you see in America is the private nursing homes. We don't have that kind of things in the Netherlands.
The nursing home,
Yeah.
long-term care.
So
The long-term care is done. Is your at home? Okay.
I was in a nursing home with all rich people, and the nurses were also rich because they would have manicure and earrings and gold and. Okay.
Is this San Antonio?
No, it was I think in the New York area.
Also in the Netherlands.
Yeah, but not like that. Yeah.
So nursing homes are always facing a very financial a battle with staying in business and being financially viable, I guess. But we do have it's part of the continuum of care. We don't do as much. So where usage of care here just goes towards home and home care.
Well, we have many in my neighbourhood where I live in Amsterdam. I'm surrounded by elderly people who are living on their own in their apartment or their home, and they have home care. They have a carer to look after them and the like. From my understanding, there's also many people to try and get them out of hospital and into back to home as well. And we have a lot of neighbourhood district nurses, particularly in Amsterdam, quite a lot to then come and look after the patient in the home as well. But yeah, there's a huge aging population where I am, and I'm amazed at how many of them look after themselves. We have one nursing home. Thank you. And I think that's about it from what I see.
I think part of the problem, because when you have, which year, which act covers long-term care
Long-term care act.
of,
Yeah. 2015.
okay. So the closest we have is if the care is rehabilitative and the notes, I'm looking at my US colleagues, and the notes substantiate in physical improvement, then the federal Medicare program can pay, but only up to 100 days, and then there's some, pays best up to 21 days, and then a little bit after that, you start running out of benefit. But for when you're really talking about custodial care, long-term care, where there's not physical improvement, you're not eligible for that. So that's when they start to try to shift those people home or to another facility, because then it reverts to either private pay or the state-based program, and the pay is abysmal. It's really terrible, really low pay for the state-based program. And that's only for those who qualify because they're very low income, depending on and the thresholds vary radically by state. So I think that's part of the challenge, and we don't have very many of those facilities that want to take or open to taking. Or they have a certain number of beds maybe in the facility that they'll permit those because they can't financially afford to have 90%, they can have a few. Right, they're not close.
One thing that's quite different from the Netherlands and the US is charity. We have our charity organizations, and that's nice to have. But in America, it's very, very important to have charity
What do
organizations.
they pay for here?
Sorry?
What do they need to pay for here? Isn't everything covered by the insurance plans?
Yeah.
Oh, yeah.
So why is there
Everything is
charity?
covered. Yeah, that's the reason.
Research, charity for research.
You
Yeah,
mean
sure.
the heart-shaping, for example?
For heart-shaping, yeah.
The brain
Yeah.
function, yeah.
But you have really big charity organizations for the children, for
Oh
yeah,
yeah, of course.
and all big events. They have sponsoring and they have charity.
Right.
That's really different than in the Netherlands.
I think what he's saying is maybe because it's not needed here because it's a universal coverage. Is that you're saying? Okay,
I don't know if that's entirely true because, for instance, in cancer, there are a lot of charities who sponsor specific areas that are not covered by the.
Yeah, sure.
I think it's more like long-term care doesn't always get the full, covered by the state. So, for instance, in specifically the area I know most about is young adults with cancer. So some nurses, I don't know if it's the same in the Netherlands, but in Belgium, some nurses are paid by charity because they are specifically trained and experts in young adults with cancer. So half of their salary or some part of the day they are paid by this charity to provide more support, specifically where they start group or more psychosocial support or more specific services for these people that they would normally not have. So that's probably it's really related to the context of the hospital and the region and
We know the nurses who give palliative care.
Yeah.
That's mostly volunteer. I think
In the
that's-
Netherlands here?
Yeah, in the Netherlands.
Because palliative care is not covered.
Yeah, the volunteers.
The volunteers,
Yeah.
not the nurses, they are paid.
Yeah.
But one nurse and 10 volunteers.
So what kinds of services do you need volunteers for in that context?
Sleeping, the sleeping time of the patients, they are available at the moment in the houses.
Okay. Just for an additional presence there to help with,
Like a sitter, like a home sitter, yeah.
in their homes.
In their homes, yes.
Okay.
like charities also help for supporting people, so families. So you have charities paying for, if your kid has cancer, a charity would set up a center where your family can sleep, or they would pay for childcare or stuff like that to support the families with people with cancer.
Yeah.
Yeah,
We have
but
that here.
yeah, also in Melbourne, but we also have other charities. There are many charities that focus on these areas because there are areas that are not part of the medical cover. It's not a medical EGR, what's it called? Diagnosis-based group.
But maybe it's the future for the Netherlands to have this charity, because the future for the district nurse is to make a cooperation with the volunteers, the district nurse and the caregivers, and work together. Maybe.
And how about the networks by the care? Because there are a lot of networks.
Yeah.
Is that a mechanism or system to connect the nurse and the volunteers?
But also in normal situations,
Oh, yeah.
diabetic care or
Oh yeah.
in home care situations.
Yeah,
So apart from this palliative care.
Because there is a multi-problem.
Yeah.
As Bianca mentioned about pediatric care in the US, and I worked with this one pediatric hospital, and it was rehabilitative and habilitative for neonates through age 18 or even older, because a lot of that, and children are disproportionately covered by the state-based Medicaid systems. The pay is really terrible. So, and they were 80% of their payer mix. We talk about the payer mix because we have multiple payers, and you need a balance to be financially sustainable. So they were on the order of 80% Medicaid, the low-paying state system. So they literally did not have enough revenue coming in to cover their costs. So they depended completely on being able to do charitable to cover the balance. But most hospitals, even peds, right, Phil, I kind of look to you, are able to balance the different components of the payer mix so that they can break even or have a small margin. Even on the peds side, I know peds wasn't your core area, Phil.
Correct, yeah.
I mean, do you have any input on how that plays out on the adult side with the payer mix phenomena? Since that's not something they have to
You're saying offsetting the.
Yeah, or at least being conscious in the strategies around trying to manage the reality that all the payers are different.
Correct. When you implement service lines that are going to be more attractive to the nicer payer mixes, so that you can continue to run your basic services for the whole community. If at the end of the day, hospitals go bankrupt here. We learned about it yesterday or the day before, so I don't know how often it happens, but ours is very much driven on that payer mix. If it's our Medicaid, hospitals typically do not make money on, but when it's a commercial insurer, they will make a lot of money, so it balances out. Medicare, most of the for-profits are somewhat profitable on Medicare, and most of our, the bigger portion of patients coming through are going to be Medicare, depending on where you are, obviously, but if you can become profitable as a hospital on Medicare dollars, whether that's the insurance for elderly 65 and above, then you're in a good situation. Because if you're profitable on that service line, on that payer mix, then you're going to be profitable in the commercial.
Thanks, dude.
Hey, thank you. So, yeah. So that helps out.
Yeah, well, we talked like in your, so Phil taught me and Deja about finance class, and we have also talked about trying to change your payer mix and how you go about doing that. You literally have to implement service lines or market to your service area to people who have that commercial insurance. So those are the people you're attracting to your facility, so you can remain profitable.
Orthopedics, labor and delivery, you're going to get good payers. Typically, labor and delivery, you're going to have commercial insurance, especially if you're located in a suburb community that is a higher wage index or working professionals. Those around your hospital are going to come in with commercial insurance that's going to pay you more money, so you market to that. Of course, there's hospitals that are considered safety net hospitals that were the downtown centrally located hospitals, or a hospital that would be similar to Erasmus MC, like an academic medical center. They're going to receive anything and everything because they're the level 1 trauma and everything goes there if needed, regardless of payer. They're going to have smaller margins, maybe even in the deficit a little bit, but grants will come in, local or municipal grants of some sort. The county, the state will fund them and give them money towards that. Or they branch out and do something else, like academic medical centers are going to get money from research that they're doing, and that's going to help subsidize some of the stuff that's, or the GME you talked about. That'd be a good example. Graduate medical education, they'll have a program like that to help. Yeah.
Okay, maybe a question. How's the position of a university hospital? Is it high ranked, or is it in comparison to other hospitals?
You mean
If you look at the Netherlands,
like the public perception of it?
Yeah.
Well, I think the perception is prestigious.
What was it? The physician, you said? The physician?
Or the
Yeah,
organization.
position of
Position,
a hospital position.
Yeah.
So it's prestigious or more prestigious than other hospitals, or how is it in America?
I'll start with the St. Louis market, where there were 2 academic medical centers. They both reviewed pretty positively, one very positively, such that they were actually able to charge 20 and 30% higher to private payers than the surrounding competitors. Not for profit, by the way, it doesn't matter. So yeah, so they were able to charge those kinds of prices because they had that perception in the community.
Okay.
And I think they attracted great doctors from around the country, but they also attract patients in need, especially for any very complex conditions. It was kind of known, when you have something really scary, go there. Except the traumas that came to our hospital. You get shot, you want to come to our hospital. You don't always have a lot of choices, but right. But so I think prestigious, but the challenge can be because they have that higher level of capability, like the highest level of trauma, for example. They also look at, and they're not usually not for profit, but not always. They also get a lot of that no pay or low pay business. So their financials can be really challenging. I'll let Phil talk more about that, but the financials can be challenging because they get challenging cases. And the clinicians want the challenging cases, which often have no insurance or bad insurance, because that's how you strengthen your skill set and train your resident and your interns by getting more of the gunshot wounds and the stab wounds and all of that, because it's a great ways to learn. They don't pay you, it's a great way to learn. Yeah, one of the reasons that fueled our trauma, we were closer to the Illinois border, maybe 3 kilometers or something. And you know that we have different state regulations sometimes. So one regulation that was different on the Illinois side of the river, of the border, was not required to wear helmets for motorcycle riding. So a significant number of head traumas came by helicopter, and we were the first level 1 trauma center, the first one they came to, so most of the time they would stop. And so we got a lot of great head trauma cases. Great, meaning academically fulfilling. Right? So it's neurology, there you go. Whereas the other trauma center was a little farther, but they also got a lot of that. Whereas the state that they were located in had a different policy, so they had fewer of those traumas. But on the other side, again, the other state, the nearest trauma center was quite some distance away. But then that could bring in payer complexities because they might have different insurance. If they were on the state Medicaid system, that's a different state, a different payer, also bad, but just another complexity when it comes to the administrative side at the hospital, billing all these different hundreds of payers instead of, what, 12? So we're at 12 in the Netherlands.
And remind me, a procedure done in a hospital is going to be reimbursed the exact same regardless of that patient's insurer or no?
Yeah, the exact same. But in some cases, when you go to a hospital as an injury and the hospital is not contracted by that insurer,
Oh, okay. Then that would be
80% or 75% of the fee is reimbursed.
Yeah.
And you have to pay 20% out of pocket.
So then the hospital will bill the patient for that.
Yeah. Or the insurer, so the hospital via the insurer. So you will have you will be invoiced by the insurer. Like, we pay
So as a
80%.
patient, my insurance will bill me that
Yeah.
20 or 30. Okay.
And
Yeah, but you have the choice to go to another hospital.
What if there's not a choice? What if it's emergency care?
yeah, I think emergency care is
Now,
probably-
emergency care is always covered by
Because the patient literally has no choice.
Yeah.
I know I'm dying, but can you take me to that hospital with this one? But yeah,
That happens in the state.
For sure.
And we
if the
have
person is
contracts with
conscious
other
enough to think about it,
hospitals.
yeah.
We have
I always told my
hospitals-
wife, if something happens, don't take me to this hospital, which is
Yeah.
nearby. It'll cost us too much and they're not good.
Yeah.
Take me the extra 10, 15 minutes drive to the other hospital.
I
Knife and gun club.
had a patient who 110%, I'm fairly certain he was having a STEMI. He, heart attack. He was like sweating, chest pain. He was like, "Do you take my insurance?" And I was like, "I can't answer that question because it's an EMTALA violation. In the emergency room, you can't." And also as a clinician, I didn't know. And so he was like, "If you can't answer it, then I don't want to come here." And so he literally left. And I was like, "I hope you're okay."
I hope you will die.
Yeah, I hope you don't die.
Well, that's interesting because a lot of people in the Netherlands are not aware of that policy that you don't get fully reimbursed. So, do you take my insurance? Is another question we usually ask. I had a friend of mine who went to hospital, or he got referred by a GP to hospital that was not fully reimbursed. And he was asking me, "How is this possible?" I said, "Yeah, that is possible, but it's weird that the GP doesn't tell you that that hospital is not fully covered." Yeah.
And you can't know as a
You
GP.
can't, yeah, that's
can't
also
know
weird.
whether-
Yeah.
The GP has to know about contracts between insurers and hospitals.
Yeah, but it's very simple, right? Just the system, you're insured with Silver Cross. Yeah, they're
it's
talking
a
about the
contract.
EMRs and
They at least should know to
systems.
ask. The
Yeah.
GP needs to know to
Yeah.
ask.
Yeah.
Maybe they shouldn't have to, that's a policy question. But
Yeah, that's another question.
That's the
In
reality.
the system, yeah, the reality, of course, it's important to know as a patient how much you're gonna pay out of pocket.
Yeah.
I'm not sure if it's a physician's job to.
Yeah,
No, it's not a physician's job.
because as a patient you can see that, right?
Yeah, you can see
Yeah, you
it.
can see if you log in. I can. If I
Yeah,
log
you
in, I
can
can
see
see
it,
that. Yeah, for myself. Yeah.
But in the hospitals, when you are going at home,
Yeah.
they ask you, do you like the care of that organization or that organization?
Yeah.
And they don't say that organization, it has not a contract with you.
Oh, yeah, no, they don't. Yeah.
And then they come home and they have to pay.
And they pay to the insurance company, you said that,
Yeah.
or to the hospital? So the hospital doesn't.
No, no,
No, the insurance.
Insurance.
You
Yeah.
pay the insurance.
And we don't.
No,
We get the bill from the provider,
the doctor in the hospital.
which is also going to, because it makes that three-way relationship even more complicated. So what if the payer hasn't yet paid the hospital? This happened to me multiple times. So I get a bill for $20,000 or something. Yeah, I had ENT surgery. No, yes. I had ENT surgery. Right, they do the boring up the, yeah. So they did that. And I don't know what's happening behind the curtain, but there's some prior author, I don't know what the problems were, administrative problems. And it just took time. I knew it was going to be covered, but in the meantime, the hospital sent me a bill for 100%. Maybe it wasn't 20, but it was very nearly 20 if it wasn't $20,000. After I got over the heart attack, the STEMI,
Which
I realized, oh, they probably haven't talked yet. And sure enough, then I had to call, and then I, as the patient, became involved in the middle of all of this stupidity and dealing with getting it fixed. And eventually, they paid what they were going to pay, and I had to pay, I don't remember, $500 or something, whatever my portion was. Then you talk about contracting. So one of the challenges we have that the federal government has actually started to address, they're not far enough yet, to my knowledge. So, the thing about being a surgical patient is that there are points in the healthcare experience when you're unconscious. Did you know this? Right. So the hospital can be contracted. And we at this table have a little more than average healthcare knowledge, right? So we have health literacy. So I think, I should check with my insurance to make sure I can go to this hospital, which I know in advance I can't. It's owned by my university. Okay, so I pick the hospital, and I know the surgeon is one of our academic staff members. Great, okay, excellent. What I didn't think to ask about was whether the anesthesiologist is in the network. Also, how do you know who you'll get, right? Don't they rotate? I don't know. So on my first, they had to do 2 surgeries, unfortunately, but the first EMT surgery, they put me to sleep. I don't know the difference. They're all wearing scrubs and wearing their masks, and they're nice and they're communicating. And yes, we're gonna, put you out and hopefully not kill you, and then we're gonna do your nose, and then you'll wake up and okay. So great, I do that, and a week, 2 or 3 later, I get a bill, and it shows the insurance not paying for the anesthesiologist. And also, I want to know why did we need 2 anesthesiologists? They had 2. Was one a resident? I was getting charged for the attending and the resident.
Probably you probably had a CRNA and an anesthesiologist.
I got billed for both. It wasn't exactly the same amount. One was slightly lower. That's very close.
I'm certain that's what it was.
So, and unbeknownst to me, not in the contracted network. Well, I wasn't the only one, and this was starting to make the national news, these kinds of things. And so there was federal legislation, happening to try to address some of this, because the patients don't know. And the next surgery, a few months later, because they had to go in and do a thing, but longer story. But, so, fool me once, shame on you. Fool me twice, shame on me. So I decided to ask the second time. I knew the head of the anesthesiology department, so I called him. Didn't answer, of course, he was very bad. Send him an email, no reply. I really want one of our anesthesiologists this time. I don't want any more surprises. No reply. No, I got another one of the third-party anesthesiologists. The same thing happened again. I had a whole patient petition process. Eventually, they covered it as if it had been an employed anesthesiologist. But again, the contracting problem. Sometimes it's more visible to the patient. Sometimes it's not intuitive that this is a risk.
Well, it's funny because so when I worked in the endoscopy lab, there were a ton of patients who would ask. They were coming in for an outpatient, colonoscopy, whatever. Hey, is the anesthesia person? Are they contracted with my insurance, or is this going to be covered? And me as a nurse who's like pre-oping them, I'm like, I have no idea. That's a great question. I don't know. I hope so. But I felt so bad because I don't want my patient to get a $20,000 bill. But how am I to know?
Right. Now we do have this protection on Medicare, the federal program, because my old insurance organization, we dealt with Medicare. So some physicians, just like you've told me about, choose not to contract.
Mm-hmm.
So just like here, they can accept 75, 80 something percent.
Mm-hmm.
We have a similar term that's called non-participating provider status. So if that provider doesn't directly bill the federal Medicare, the federal Medicare, they can instead bill the patient. The patient submits the bill for personal reimbursement to Medicare. They can do that, but then they won't get 100%. They'll get, the non-partial 80 something, 90%. It's less.
Yeah.
But in that case, that clinic has made a business decision. They don't want to screw around with having to deal with insurance. They just go to the patient and let the patient solve the problem.
Is that the UCR you're talking about? The usual customer?
No, it wasn't UCR, usual customary rate. It was Medicare.
But if the patient goes to Medicare, then Medicare pays the hospital, or the Medicare pays the patient?
This was an outpatient surgery group. It wasn't a
We
hospital.
just say Medicare pays the hospital and Medicare pays the physician, the providers.
Okay.
Yeah.
So 2 bills typically. Facility,
The provider has to be willing to submit the bill to the government insurance. If they don't want to, then the patient has to decide if they want to go to that person or a different surgeon. And that these were this was an ophthalmology clinic that I used to work with. And they decided they weren't going to bill Medicare. They just didn't like it. I don't know what all their deal was, their problem, but they billed their patients.
oh, and I think what they do then is they have the patient take on that responsibility of getting reimbursed by way of like submitting the claim themselves.
Yeah, so then you have to do it.
But I feel like that is a smaller.
Yeah.
You know.
But this was a very well reputed ophthalmologist, so some people really wanted to go. So we have a little bit of that. It's not very common that that phenomenon exists to a degree, but that's only with Medicare. Otherwise, if they're not contracted, you could be responsible for 100% if your insurance doesn't have that. I mentioned that academic medical center in St. Louis that had the really high reputation. I remember when the Obamacare, Affordable Care Act insurance exchanges came into place. And I was doing exercise for my students where we were shopping online for the different options for insurance. There was this one by the same company, and I couldn't understand why the one, let's say an example, I don't remember exactly, but it was $100 a month premium, and the other one was like $130 a month. So I clicked on them, and I'm looking at the benefits, and they seem like they're the same. One did not include that hospital network, and the other one did include it. And the difference, actuarially, was something like $30 or $40 a month, just to include that one versus not, because their prices were so high. And they're supposedly not for profit. They're sitting on over a year's worth of operating cash in their accounts right now, actually. I think I heard $14 billion. They're sitting on that much cash.
It's a lot of cash.
And this isn't a nationwide provider, this is a regional provider.
The state provider or regional, so it's
They reach out about 100 miles at the most from their headquarters. Yeah, not very big.
because you have Medicare, Medicaid. Those are state-regulated insurance.
Medicaid is state.
Yeah.
It's cooperative. So a state decides how much money it wants to contribute, and it goes to the federal government. And if it's a rich state, it's 1-to-1. So like Massachusetts, you talked about being in you went to New York? You went to?
Yeah, New York, Bronx. I went to
I
Bronx.
think both. I think both. You didn't go to Harlem?
Yeah, I guess so. Yeah, I was there in the hospital. It looked like a battlefield, but then continuously. So patients everywhere, gunshot wounds. There were lying on stretchers in the hallways, and wow.
They probably were
I
getting
get to
Harlem.
MGH, but
Our Harlem is not as nice as your Harlem. And our Brooklyn is not as
We
nice
got a
as
kick
your
out of
Brooklyn.
the ER physician saying that she was like overwhelmed and busy.
Yeah.
That I like saw like one patient.
Yeah.
So the rich states,
and
the rich states get 1-for-1 matching. So if they come up with $1 billion, they get $1 billion from the federal government, and then they implement it with some requirements and guidelines.
Yeah.
The poor states can get 2-to-1. So a poor state like Alabama or Missouri, like where I have been over the years, they only have to put up, if they put up $1 billion, they get $2 billion back from the federal government because they're poor. So, but again, then they have criteria. And now, since the last 25 years, approximately, the federal government has started to allow more and more what they call waivers, basically the opportunity to kind of have a customization of the program. So my old home state, Oregon, was one of the early pioneers in putting in a waiver because they wanted to do use the same concepts that you use in Europe about cost-benefit analysis, which is otherwise not usually allowed. We don't the federal government doesn't permit cost benefit analysis to come into decision making, which is interesting. So they decided they wanted to allocate their limited Medicaid dollars with a heavy emphasis on public health. So they have this prioritized list of services, which are ranked by an expert panel as well as with cost benefit analysis with a very societal perspective. So it covers very richly on all the preventive stuff in prenatal care. And then as you get things where that are more individual focused or less evidence-based or more risk, that the result will be, an example, back surgery. Usually what happened is around the back surgery level of this prioritized list, things weren't covered anymore. And heart surgery, transplant, none of that was covered. And that was in the name of saving money, because otherwise what happens when states start running out of money, they kick people off. So they go from having terrible insurance to zero insurance because the state ran out of money. So Oregon wanted to change that dynamic, and they said instead of throwing people off, we'll cover fewer benefits, but try to maintain as many people. And so that's what they do. And they had a huge public outcry because there was a very public situation with this little boy and he needed a bone marrow transplant. They said, no, we're not going to do it. And it was very much in the news. This was in the 90s. And he died because they wouldn't pay for it. And they were sued and they stuck by the decision and it ruled in their favor. But it has enabled them to keep that perspective. It's very atypical of America for sure, and not typical of other states, but that was the perspective. That their governor was an ER physician. So he had that emergency background.
Do insurance companies do they push quality outcomes here? Is there pressure to reduce length of stay from insurance, from managers of, administrators of hospitals? Where's it coming from mainly?
Healthcare insurers, and
Okay.
then they say that's the quality of care if you reduce length of stay.
Yeah.
And that's what I meant. Okay, I can steer on length of stay. It's no problem. I kick them out.
Yeah.
But they're paid on DRGs, not per diem. Is the hospital paid per diem or DRG?
No, I'm not sure.
DRG, but there are DRGs for the same diagnosis but with different lengths of stay. So you have a DRG with 10 days of 14 days, 30 days, more than 45. So,
Okay, so we have DRGs with level of complexity, which would be analogous to that. So there's more money if the person clicks into the next category of length of stay.
yeah. So it depends. If you stay 14 days, you're in the maybe $1,000 range, and then you stay 15 days, it gets to $1,500. So it's that's what you said. But we also have different levels of complexity. It's not only length of stay.
Okay.
It's also
So ours is not connected to length of stay, right?
It is.
The DR
After a certain time, we get higher reimbursements up to another point in time.
But is that related to like the major complications or those adjustments?
Complexity, yeah. It's to cover hospitals that if the patient truly does need to be there and there's nowhere else to go, the hospital will be reimbursed on that. And then after a certain period, there may be no reimbursement, and then it kicks in again. I can't remember what it's called right now, but there is a financial piece component to it. Hospitals don't try to seek that part out. They try to stay within the length of stay that is permitted, if you will, reimbursed. But reducing length of stay appropriately is always a big push in our hospitals as well.
But less so from the insurer side than the hospital finance side, right?
Both.
Turn over the bed faster.
Both. Both. Hospital insurers will sometimes put their own hospitalists into hospitals to manage that length of stay. So we have insurance groups that will own physicians, employ physicians to help manage the length of stay, because that's how it is.
Yeah.
No, I'm good with that so much.
So, but what you were talking about the cost benefit analysis, that is something we do on a national level in the Netherlands. Yeah.
So the misperception and the bad the bad publicity at election time about that. They start calling it death panels. The idea that there are some bureaucrats that will decide if you get care or if you just get to die. That's the way opponents to your policy in the US tell the story, which is a misrepresentation. But that's the excuse for how they want care to be provided by need, irrespective of cost benefit. And we know that it's more complicated than that, right? If two drugs are almost the same, one costs 10 times as much and gives little or no additional value, we could argue it's fair to argue maybe we shouldn't use that drug.
Yep.
But that's not permitted right now. So as long as the drug is efficacious, we're just focused on drugs, it can be used.
Yeah.
It doesn't matter what it costs. Same with orthopedic implants, which are a big cost problem right now.
Yeah.
As long as it's efficacious and approved for safety reasons, the price is not considered in that decision.
Well, I think we have the same, so apart from the discussion about what's in the basic package, there is a discussion about expensive medicine, right? And what the euros we want to spend for an additional life year in good health.
Yeah.
So in that sense, we're at the same stage.
Our insurers will deny that
Yeah.
purchase. So that's where it's driven by. For example, in vitro. Well, no, it'd be before the whole legislation passed for IVF. You know, some states, again, it's state by state. Some states said insurance said that we will cover in vitro IVF, right? And other states have said no, we're not going to. So it's approved. It's a practice that's approved if you know how you described it, but not covered by insurance. Now you can pay out of pocket, you can pay cash for it, but the insurance has the right to decline that. Decline.
Now, do they make those policies on some? Do they hire health economists and they're doing health, cost benefit analysis, or are there other bases, to your knowledge, Phil, on which they're making those
I think
policies?
it's just a state use the insurance. What services they want? Are they expanding services, or are they restricting services for the purpose of what's covered and what's not covered? So.
I would say medical necessity, it's not necessary.
Yeah, Alabama, even when IVF, is IVF illegal now? Right now, what's going on right now in the States?
UAB can do it again. They are practicing it again.
Really?
Mm-hmm.
Okay.
But we're out
But,
of business for like a week.
so I was gonna ask about insurance here. Do we see, are you all seeing year in the year, when you say in October, they meet with insurance groups and reimbursements are going down, and do you see services being limited as well? But what's being covered under the, the base plan, is it called essential benefit? What is that called? The base plan?
It changes every year.
What's covered?
Yeah, what's
Okay.
covered, yeah.
And do you see certain services covered by insurance being removed, where now the financial burden falls on the patient if the patient needs it?
But this isn't in contracts, right? This is on a national level. Like every insurance company has to reimburse the exact same basic package.
So if
Yeah,
one
and the
does it, they
basic
all have
package,
to.
yeah.
Yeah, exactly.
Okay, I see.
But we have the basic insurance and we have supplemental
Okay.
insurance. So
And
all
what-
Dutch people have the basic insurance, it's
Uh-huh.
mandatory.
Yeah.
And then you can have the supplemental, so that's only for the people who can pay it.
And the supplemental is also equal to the supplemental of another insurance
No,
company.
not,
The services
that
offered?
changes.
Oh, that
For
changes.
example,
So that becomes
they
more of a
have-
market.
it has different packages, so
I see.
every healthcare insurer has a supplementary package, but they have maybe 4 packages supplementary. So physical therapist is cheapest supplementary package, you have 10 treatments of the physical therapist. And in the best package you have unlimited physical therapist. So that depends on, and some in healthcare insurance you can take your physical therapist treatments to the next year, so you can take them with you if you haven't used them. But others you use them, if you don't use them, you lose them.
About what percentage of the population of the Netherlands has supplemental insurance?
I don't know. anymore. I guess, I think most of them has supplements. Not in Rotterdam. Rotterdam, not.
Amsterdam wel has basic.
Amsterdam.
I just drink myself.
Yeah. And I mean, also for me, I change my supplemental, each year. So based on, my physical condition. So for physiotherapy, I needed it last year because I knew I had an injury, and I think I might need it again this year. So I kept it. But then if I feel I'm okay, I will let that go next year.
Is that something you can add on like any time?
No,
Or is
you
it
have to do it before the 31st.
Well, so the reason I ask is because so I was in an accident and I hurt my back, so I needed physical therapy. But I didn't know I was gonna need physical therapy at the start of the year.
Yeah.
So you just have to wait. Yes. Okay. Wow.
We have some patients, and about some years ago, physical therapists was not in the basement.
Yeah.
And then they come home
What is it?
for rehabilitation, and they need a physical therapist, an acutherapist, the whole package.
Yeah.
And then
So they're just like
it's
sorry,
like
go home. Like, wow.
Yeah.
You can pay it yourself.
But apart from the physical therapists, we also have like dental care and supplemental packages, and also alternative medicine, so like Chinese medicine. So it's really a variety of choices depending on the supplemental package.
Why is dental, now that we understand today how dental is integrally involved in physical health, why is dental still carved out of the Dutch system?
Because it's really important, dental care, and it is really expensive.
Yes.
So that's why it's included in the
But if with my package, if I have an accident, then that's covered. So if I fall over and smash my teeth open, that's covered in the.
But I just mean hygiene, like cleanings and basics.
He's saying why is it not included in the basic?
Oh, not included.
Yeah.
Is
Is that what
It's
you're saying?
related to your health. If you neglect it, it has bad physical health conditions.
Yeah, but-
we didn't know this 20, 30 years ago.
yeah, but in the basic is well the cleaning and the
cavities.
Oh, that is covered?
Yeah, about
No.
120 euros.
No, but it's supplemental, right?
It's supplemental.
Oh, right.
Oh,
Many
yeah.
people insure dental care supplementary.
Yeah.
And it's in the basic package for up to 18 years old.
Yes.
But not for adults. It's not in the basic
But
insurance.
when you cover other preventive care, why not this?
Well, I think that you have to draw a line somewhere, right? Because someone may say, why is something else covered or not covered? Okay, we're talking about dental here, but I'm hopeful that there's a committee that sits and talks about, do we have enough funding from federal government budget to now include dental and basic coverage, right? And if we do we have to take out something else someone else is gonna come and advocate for that?
Well, long-term care is added, right? There's
Yeah.
almost.
So where do you stop? Where do you stop?
Well, and I'll give you an example. So I talked to the physician. So my father-in-law needed heart surgery, and they would not operate on him until he got his oral health fixed. And he hadn't been to see that. It's been 20 years or something. Now, he also didn't want to go to the dentist, and so he delayed, and then he died. So that was not the best decision he ever made. But there's a relationship between, again, I'm not a clinician, so. But historically, these weren't covered in the US either. I think it's more recent that that's being recognized and woven back into coverage. Medicaid does this now. I don't know about the state of Alabama yet, but a lot of states do this.
How often is the tax? Okay, I from Silver Cross, I know it depends on income. If I remember right, they said that the max tax rate, if you make a lot of money, maybe a 7% that you'd be taxed for the insurance. Does that sound right? Well, whatever that percentage is. The question I'm trying to get to is, how often is that tax raised?
I'm not sure what you mean by tax.
Like how much of your income tax would go to healthcare in general?
Correct.
I suppose.
Like that.
Oh.
I don't think we really get a breakdown of that on our paychecks.
You do or do not? You said
We don't. We don't.
Do we? Yeah, we do. Yeah, we do get, yeah.
Is it itemized?
Stating
Ja, volks,
Ja, volksverzekering.
ja, klopt.
it's part of,
But that's also
Apparently I don't check mine.
So there's a line.
It's not even my tax dollars are going. My payment
It's
is
in my
going.
account, that's all that matters.
So there's a line that's for
Roughly-
I didn't think for not speaking. There's something that I said.
Roughly, we pay about
also long-term care.
40% taxes.
40.
40, roughly.
But what all do you get for that? Because I only take
How
home
much
60,
of the
65% of my
national spending, like the budget of the government, goes to healthcare? I guess that kind of answers the question.
Yeah, and is it a deficit or surplus each year? And the reason why I'm saying is because maybe they say one day, yes, let's include dental, but we're going to bump up from whatever number I had 7% in my mind for some reason. We're going to bump it from 7% what you get taxed to 8 or 7.5, so that we can also cover dental.
Yeah.
And if they did, would there be an outcry? Would there be like, no, it's not, right?
But what's included in the basic package is also something that is discussed with the insurance itself, right? Between the government.
yeah, the
department
healthcare institute decides what's in the basic package and what's
Yeah.
not. And that's,
And the council?
Yeah.
the Zorg Institute.
See.
And that's part political decision making in parliament, and then there's a scientific advisory group within the healthcare institute that decides and advises on what should be and what should be out. But I think in the current climate, if we say we want dental care in, because there have been pleas recently to include dental care in the basic package. But then in the, what you said, the fact is that premiums will go up or taxes will go up. Yeah. And then it's just a solidarity question. Do we want to pay for dental care for everybody?
Yeah, exactly.
But downstream it will probably generate savings and be cost effective.
If it's integrally tied to the rest of your physical health.
Yeah.
Like I'll give you an example. I can go back to Oregon. So Oregon used to have the physical health part here, mental health here, dental health here, and drugs. And when they did their second rev of reform, 15 years ago, they put them all together because they realized that the literature now supports that comorbidity and that interrelationship, especially between mental health and physical chronic conditions, like depression and diabetes go together very closely. So why would you, their practical question, why would you treat this but not treat this, or make them into disjointed policies where they don't coordinate? So they force them all together, and they force them under one bundle capitation payment for all of it. So it forced the behavioral people to talk to the physical health people, even though culturally they weren't doing that for it. It forced the dental to be integrated as opposed to separate programs. I'm not saying they're right. In fact, in the US, they're looked at as a bunch of crazy leftist wackos, but that's my own.
But we have also a problem of mouth care in community care. Mouth care
Dental care.
not dental care.
Not only dental.
Not only dental, but
Mouth
Hygiene.
Yeah.
There's no separation in that with our dental insurance. That's all together. It sounds like not just dental, but also cleanings and fillings, or is that what you're saying?
Oh, and prevention.
And prevention, yeah.
Because elderly people are not going to the dentist and they have problems and they have heart problems.
Yeah,
So
exactly.
they,
That's the relationship he's talking about. Yeah.
and there are also dentists available for the community care to show how to do and do it for free.
Yeah. Are dentists want it included? Do they not want it included? Because then does that cap off their reimbursement? I don't know.
I have one point of reference. So when I was here and I would go to the Rotary, one of the Rotarians in the club was a dentist, and he complained loudly how it wasn't included in the one.
I wonder what would happen to his reimbursement per patient if it was.
Well, that's a good question, right? If he's busy and the government said, oh, instead of paying you 100, we're now only going to pay you 70, maybe he would change his tune.
The prices are set already.
That's the supplemental price though, but when if it becomes a basic service, wouldn't that price come down, you would imagine, because now it's universally covered, it should come down, but at the same time, does that provider want to do more for less in order to stay at that same income?
Hopefully, yeah. Yeah.
So, yeah. I mean, it's just,
I feel like that's what a lot of the dentists, like my dad is friends with a lot of dentists, and like there's been a couple of them that they went ahead and retired because it's gotten so insurance heavy in the States because they're not getting paid what they were getting paid when they just were a cash business.
some dentists have continued to stay cash only and not accept any insurance for that purpose. So.
But